Good morning and welcome to day 2. We have a very slight technical hitch in that the hand control is not working, nor is this one. So I'm improvising and pressing the forward on the screen, and I'm going to get us going with a little bit of welcome and housekeeping. So I hope you all had a nice evening yesterday, and thank you all for being here nice and promptly. Very brief intro and housekeeping before I introduce Professor Lucy Chappell. Now, come on. You did it. Okay, so I think I'm just going to say, whilst they, oh, here we go, we've got the next slide, we know that. There we go. This is the programme for today, and thank you. Quite a few of you in the audience are in green, because we're doing Wear Green today for Mental Health Awareness Week, so thank you for that. You've all got that on the back of your name badges, and just to remind you that the programme is here. Remember that there's a Slido for questions if you would like to use that, but also will take questions from the audience. Housekeeping, fire exits, I think we found them yesterday, but a number of people are here today for the first time. So fire exits at the 4 corners, not expecting a fire alarm. If there is one, the staff will help us and guide us to where we need to be. Toilets are straight across, past the bar, and you'll find them there. Breaks and refreshments will all be taken there. Remind to look at the posters. Wi-Fi, I think we all found yesterday, and it's just a public Wi-Fi for the library. So, and a quick reminder that we have Bhagesh with us this morning again. So if you don't want to have a photograph taken, please let him know. And getting the most out of the ASM, and visit the stands, join the conversation, and reminder that we have got the quiet space if anybody needs that. So I'm now really delighted to welcome Professor Lucy Chappell, who is Chief Scientific Advisor for the Department of Health and Social Care and CEO of NIHR, which I think we all know. Lucy has overall responsibility for DHSC research and development and for supporting the department's analysis. Lucy also has a day job. Lucy is Professor of Obstetrics at King's College London and an Honorary Consultant Obstetrician at Guy's and St Thomas's NHS Foundation Trust. And she's President of the Blair Bell Research Society. She's a former senior investigator, former NIHR research professor, and was previously a member of the NIHR HTA board. Her research investigates prediction and prevention of adverse pregnancy outcomes, particularly in women with conditions such as hypertension. Lucy, you're very welcome. Lucy is going to give her presentation, and then we'll take some questions. So thank you. I'm just checking with my colleagues as to whether this has actually worked. Yay! You're on. Thank you, Lucy.
Thank you very much. What a lovely welcome. When I was emailed to be invited to this, I jumped at this opportunity, particularly to reach people across an area of NIHR and really of our health and care system that I think is so critical to the future. So I've put together some slides. I hesitated because I was actually still writing them this morning, and some people know that that's how I sort of how it ends up. And I really want to think about how I would like to really have a call to arms for this audience to be so much part of what is happening in health and care. I say that on a day that is may well be particularly eventful for our health and care system, but really to ensure that my ask of you is a big one, and I would like you to be a critical part of it. I've gone from being a clinical academic, like many of you, and in fact, yesterday afternoon, I was sitting in St Thomas's doing antenatal clinic, and at first hand in Lambeth, I see what both individual person health, but also population health means it is an area of high deprivation, very mixed ethnicity. But what we can do both at a population and an individual level is critical to the health and well-being of the pregnant woman and her family in front of me. But then in my day job in government, I also sort of zoom out to what this slide represents, which is what comes through the manifestos on the left, the money on the spending review, and two big plans, the Fit for the Future 10-year health plan and the life sciences sector plan, which have really shaped major parts of our policy. But what does it actually look like from your perspective, and where do I think the challenges are? Well, like many countries, we know what the demographic pressure is looking like and stacking up to be, both in terms of the ageing pyramid of our population, but also in terms of multiple longer-term conditions. And those are just two of the sort of demographic pressures that we could name. We've also seen that the pressures on our health and care system are substantial, and I've picked both the waiting list, but also for me, something around the waiting list for children and young people's mental health that speaks to many different facets of those waiting list pressures. And again, where we both see an opportunity from the public health point of view, but pressure on the system. We can't but help describe the inequity pressure by deprivation, by geography, and by many other characteristics. And I think it is woven so clearly through all of what you do, but I would say it is not without its challenges, and it's something I will come back to. I'm heading from here into a health security meeting, and because there's a large bit of me that would certainly like to stay and hear Kevin and much more, but actually there's some health security issues, not just hantavirus, which is a reasonably critical but small number of people, but many other day-to-day pressures on the health security front, including those of climate change. And you could mention antimicrobial resistance or many more. And then the workforce pressure. I'm sitting here with many of you such champions of this who are prepared to be such a key part of this. But both, if you look at something like the Medical Schools Council report, which both counts the number of clinical academics employed by universities, but also thinking our denominator is increasing in terms of the numbers of doctors, nurses, midwives, allied health professionals, public health professionals, are we keeping up with it? And finally, the spending pressure, as we have never seen before, and really reflecting our world with so much conflict in it, where the pressure to draw funding away from health and care towards defence and towards security of a different sort is very, very much clear, and that is going to impact on us. But even without those additional pressures, if you look at the curve on the right where you see if we do nothing, that spend on health increases and increases. So for me, the public health aspect of this is critical. How do we bend the curve? How do we say it doesn't have to be like this, that you just do more and more spend, particularly towards the later part of people's lives? So the treatment, how do we really enact that shift that drives prevention as one part of that public health message? So that's the sort of tough bit. I think I want to present some optimism, some hope, some what can we do about it, and that's very clearly where the NIHR sits. Some people aren't so aware that the NIHR is the funding arm of a government department. We're not an arm's length body. We are integral into the department, and I spend my days giving scientific advice to ministers based on research and evidence. That is a huge opportunity. UKRI actually is an arm's length body, so the executive chairs are not in with ministers every day. So how do we use that wisely as a superpower? How do we say that with the support of people like Kevin in the department, we are working to get that population health, that public health, that prevention message across into so much of what we do? For me, it's also about where we sit in the translational research cycle, and it's an invitation for you to be present in all of these areas. So to think of where that might go from discovery research, which is more broadly supported by the Medical Research Council and other parts of UKRI, but say how do we reach back? And I know that many of you will be working with MRC and others, but then saying go through these steps of the translational cycle, both to get translation to the community and then to join up the ends of the pipeline. It's not a left to right pipeline with everyone falling off the edge on the right-hand side. we have to go back and say what works for whom and where doesn't it work, and how do we use that to drive our discovery science. I see that in areas of pregnancy hypertension where I research, where the heterogeneity of our populations should ask us, well, what pregnancy antihypertensives might work differently for those with Black African Caribbean heritage or those of other ethnicities, where that in-clinic experience should drive our discovery science. There are valleys of death across this translational cycle. How do we form the bridges? And this is against the background of the 10-year health plan, where the 3 shifts which are driving our journeys towards the goals could not speak more loudly to this audience. Hospital to community, analogue to digital, and sickness to prevention. When this was put forward into the 10-year health plan, it was all credit to the work across NHR that I had so much to show our ministers in all of these. We didn't invent prevention when the 10-year health plan came out. We have been doing so much more, and to have this spotlight on it, it is really exciting. Similarly for neighbourhood health, what is that going to mean to this audience, and where do we see join up across a very secondary care-centric model with recognition of the part that primary care, public health, social care, local authorities, and that much bigger concept of what neighbourhood means, how do we really capitalise on the opportunities that are coming? And with that are the 5 big bets. And you can say, oh, I wouldn't have chosen those 5. How do we use these 5 for good to say this is where some focus is? What would this mean for how we do public health research? And how do you apply that into yours? Because we're going to be seeing more coming on these 5 big bets. But for me, it's only good if we can remember this. It's about saying that what we do with the health inequalities lens, and I see it both in terms of the patients, the people, the population, but also the workforce. It's just as important that we leave no one behind, and that we do that from the prioritisation, from the design stage. It is not acceptable to get to the end of your research and then find out that it wasn't representative, that it didn't reach the groups who most needed it. That's got to be built into the beginning. And making research inclusion a condition of funding sets a very clear place in where we are as a funder in saying, when you don't have to ask nicely for a committee, you are required to do that. And we really want to change how we're seeing that. There aren't hard to reach groups, we just haven't tried hard enough. So it's up to us, and the onus is on us, and we understand what that can be like in terms of the engagement that has to be sustainable. My other passion is for embedding a research culture. We've started on this journey, but it's literally just the first steps. Imagine my vision where a much higher proportion of opportunities to engage, both at the population level, at the individual level, have got research, innovation, training and education just woven through it as core to care. And core to care, but also core to care in the population health sense. So not seeing it as just those individual interactions, but so much more of our health and care system. And if I think about my engagement with local authorities and others who provide health in many different aspects, there is a real appetite there, but we have to help them, and to reduce our bureaucracy. We have to reduce the friction in the system to making that possible. But I think many of you can give examples of where that is happening and where we need to be bigger and bolder. So what does it look like from an NHR perspective? As I put these slides together, I'm so conscious that I'm speaking to a room full of experts in this area. So this isn't so much about telling you what you're all good at, but it's saying, where does this fit into the bigger picture? These are some updated slides. They're not publicly available yet, but we will make them so soon, where we look across the 8 health research categories and we say, what is our investment? So to note, this is joint UKRI, so typically MRC, but there's a couple of other research councils who fund in this area. And you can see the third one, which relates to primary prevention. It's going up. Many of you would like it to be even bigger, but actually I think there are several of these research categories where you can score your research against. But there is a commitment to increase the spend against prevention, and we can have an argument or a discussion. Is it primary prevention? Is it secondary prevention? Does the person or community care about those categories, and should we just think about it from a person-centric model? We fund research infrastructure across England. And this is some of our major research infrastructure. We've had some degree of mushrooming of our infrastructure, and there is a plan to make it coherent, because we repeatedly hear that our funding schemes and our funding investments are difficult to navigate. People don't always know where to dock in. So rather than letting more and more things mushroom, we are keen to see that convergence. And thank you to many of you in the room who are helping us with that convergence and coherence in the public health research space. So again, it's an invitation to all of you. How are you linked into these other parts of the research infrastructure? It is critical that you are part and represented there. So for some of you, it might be with the biomedical research centres. They're not just the preserve of some people over there. I want to see you involved in what they are doing in that earlier phase, so as to make it so relevant to what you do. But also the applied research collaborations, the health tech research centres. So go and cold call, go and inveigle your way in, so that there are more connections across that infrastructure. We also fund Research Delivery Network, and I'm really conscious of how we are trying to recognise that research delivery in the public health research space will look different. We haven't always got it right. This is a journey, and you are part of that. How could we make it better? Whether it's what we've termed excess treatment costs or intervention shortfall costs, how do we get it right for this community and not just assume a straight lift and shift, but when we're thinking about research delivery, what will that look like for you? This is a slide that was shared with me. Have we got that coherence and that convergence? Is this where you want it to be? Can people navigate in if they're not insiders? So how do we ask ourselves, make this accessible, relevant, make it easy to navigate? Because when I'm out and about, I still hear that can be difficult. So think about how you are a critical part of that, because it is so important that this is a part of the bigger infrastructure. We also want to fund capacity building partly through our NIHR Academy, which is what I've represented here, but much more broadly across infrastructure and programmes. And I remember when I applied for a grant in 2019, before I took on this job, I was told to take out my capacity building from my HTA grant. I'm proud to say that we've reversed that, but because I think that our programmes and our infrastructure are great places to build capacity. And also in these really uncertain times for institutions, they're a critical part of bridging for people. So I'm looking for the person who can find me something that describes people that doesn't start with not. So not a health or care practitioner, maybe people in this room. Please find me a better description. We've really struggled with that, because describing people by a not word isn't my preference. And saying, have we got this balance right? So I was proud to champion the inclusion of those in public health training who did not come from a medical background to be included in ACFs and ACLs. How much more can we do? And the answer is always lots. So show me the gaps, help us find the solutions and address the challenges. We fund programmes across the UK, so for our programmatic funding, the devolved administrations pay in a fixed amount and then have unfettered access to our programmes. So it is a four-nation, and we have a global health research, which has got some great public health research in it. So are you adequately represented? And is this community leveraging all of those programmes? Do not feel constrained to PHR, lovely as it is, and because sometimes you tell me that it's actually quite difficult to get into the other programmes. Use Adam as your programme director to be your bridge into the other programmes and to help that navigation. Tell us what we could do differently to make those programmes accessible to you whilst you still have your flagship programme. Go and be nosy, go and apply, go and put, it took me 5 applications to get my latest grant funded. So rejections are normal. I can't sort of make everyone get funded at the first round, but go and be curious about those other programmes. And then thinking about the wider public health and prevention investments, you can see, you can see that we've got investments across many places. And again, we both want that to be focused, but coherent. And so really keen to say, to be asking you and your leaders to be shaping this so that we can connect better. A huge theme of what we've been doing is collaboration and looking at both the geographical, thematic, cross NIHR approaches so that we can be sure we're leveraging everything that we need. So I'm going to finish by saying, thank you, Rachel. Thanks. I'm going to finish by asking, what does this mean for public health research? We've been clear about asking for impact, inclusion, innovation, and investment. And I just want to have a conversation with you as to whether that is, what more could you do, what more could I do to understand what this means for public health research? So impact. What I like to do is to go onto our impact page, and I dropped a filter onto public health research, and there are 6 results. How many stories would you like on there? Because I'd like some more than 6. And so I want you, and it's going to really annoy my head of communications, to bring out your best. I know you've got them because I see them in other places, but I want some more public health research because it really matters, and we've got to shout about the impact. So when I'm up in front of ministers, it's nice to do funding announcements, but that's input. What we're looking for is outcomes and impact, and to be able to say, we funded, and this is the so what, and the so what now what. And this is also about saying, who is this reaching? I also feel quite strongly about stopping stuff that doesn't work. So I have no such lines as positive results and negative results. They are all results for impact. So Ashley, this is go and get the brilliant research and impact that you are showcasing, and let's get more onto this page. Because I love some of these stories. They're all, they talk about workforce, they talk about childhood health, they talk about the brilliant Bradford work, and they talk about the great truckers story that won an impact prize. You've got so much more out there. So how can you get more of this up, on the webpage? The second one is inclusion. Now, I just chose maps because I use pictures for my slides, not words. So there is so much more to inclusion than geography, but you'll recognise that's our awards on the left, and you'll recognise the HDRCs on the right. But I'm asking you, how would we show inclusion by lots of other dimensions? Because you're looking at inclusion through so many different levels. So what matters to you about inclusion? Is it about deprivation? Is it about ethnicity? Is it about other protected characteristics? And how can you show off that inclusion approach? I think that is critical for us doing research that matters, and particularly on addressing health inequalities. But when I was trying to work out which of our data sets we could use to show that, and so what could we do better to show that reach? Because I think that this group has got examples of that. The third was innovation, and I went sort of fishing around for what does innovation mean? And I've got a very broad definition of innovation. So here are some from the sort of public health sphere. They're on the public health research landing page on NIHR. So I know about the Invention for Innovation on drug use, and some really nice examples of how, for a really tough nut to crack in illicit drug use, there are some innovative approaches. The second one is the HIV vending machine, HIV test and vending machines. So people thinking about how to tackle this differently. And I've included the one on the right because I think we need more innovation to tackling health inequalities. Because if we'd got it right using all the methods we've had so far, we would be in a better place. So there have been huge strides, but we need to think differently. And we've got Judith Rankin in the audience, who is leading the Maternity Inequalities Consortium, where we have charged her and her co-investigators to do things differently. We're not looking for more of the same. We need to think about how we approach that differently. And the last one is investment. Investment in and investment out. So these are our slides on the public health in terms of number of awards, portfolio spend over the years. and the areas that we're spending in. So that's our investment. But let's face up to the tricky questions of, is all investment in the same colour? How is this community addressing investment from, I'm not saying just into NHR, I'm saying into research, whether it's gambling, whether it's with supermarkets, all the tricky areas. So you should be owning the conversation and having it with other people in the department on the policy side and saying, how do we face up to that? Because I don't think it's easy and I don't think it's static. So how do you also leverage wider investment? How do you work with industry in an open and transparent way? Because if it was easy, we would just have one set of guidelines that didn't need to change. It isn't. So I'm going to finish by saying we are NIHR at 20 this year. Look at where we've come from. Look at your contribution to that and choose how you want to be part of shaping the next 20 years of NIHR. I think you need to be more relevant and more visible than ever before, because if you look at the pressures that I called out, it is really clear that this community has got to be integrated across NIHR, shouting loudly, being across the infrastructure, the programmes, and being very strongly collaborative. So I hope that you are ready for that and willing and able, and very happy to take questions on some of those aspects. Thank you very much, Ashley.
And thank you, Lucy. I think we just need to keep an eye on the time because Lucy needs to be away at 9:40. So we have a few minutes for questions. And I guess, Lucy, thank you very much for that presentation. I think that a number of us in the audience will be reassured by your commitment to that public health and prevention. And I guess we're looking forward to the fact that we have been all funded until 2029. I'm very excited about that. But I think there's also people seeking that assurance that that dedicated funding for public health and prevention, which you showed with that change, but also still less than in other areas perhaps, given the importance of prevention, the assurance that that will continue. Is it indistinct but also integrated?
I think you've captured it in that last phrasing, which is distinct and integrated. It's not an either or. And I think we've got to both recognise the value of public health research in its own right, but ask for greater endeavours to think about greater, stronger collaboration with others. I want you to go and, I was about to say, make a nuisance of yourselves with lots of others. I sort of mean that I'd like us to see so many more links and bridges with other bits of health and care research. So recognising the value from the focus, but also asking how you are more involved and working with people across the health and care research. So there's a sort of and a more, not an either or.
And I think that's the reassurance. And of course, many of us do work across that, but there's always room for more.
The other thing is that you are seeing that we are evolving our models of funding. And that's absolutely right. I do not run the same NIHR that Sally started in 2006. And we need the model to evolve because otherwise we're funding in yesterday's model. So the other challenge is that we are, if you look at our funding schemes, they have, as you can see, got so complex that most people find it extremely hard to navigate. So you can go down the clumper or splitter route. You can put everything into one pot. I'm not in that place. You can put everything into multiple little pots. It's got quite far down that end. So again, just what would it look like to go and be to go and forge those links while still recognising that we've got to have dedicated funding for public health research.
Okay, thank you, Lucy. I'm going to take some questions from the floor. I'll come to PI&E, Adab. PI&E.
Thank you, Lucy. That was a really interesting talk and reassuring. I just, you pointed out that there's been a great investment, which is really lovely to see and encouraging in a number of areas that have strengthened capacity and research development, capacity development in local authority and local government. So the HDRCs and the FIRSTs and the specialist centres and the work that's done through SPHR. And I certainly in my personal work have seen the excitement and the enthusiasm and momentum that's been built up through that. And I think it's at the early stages where there's lots of really exciting research ideas coming, and that collaboration has been fantastic to see. And I can see that that will have lots of potential for some of the policies that you were referring to. And I just wondered how we continue. I hear what you're saying about integration, but I guess that's an early collaboration that's been forged, and how we see that being strengthened and continued.
So I think we need to embrace the policy shift towards neighbourhood health, and to embrace what that will mean for this community, working with your own expertise and experience, but ensuring that there is a place both for that and for being relevant and a critical part of the neighbourhood health vision. Neighbourhood health as a concept is still emerging, and we need to understand how we are part of that, co-creating what that's going to look like. So how do we get, as we see neighbourhood health being shaped, how do we say what works? What's the evidence about what works? What are the gaps, and where does R&D fill those gaps? And for me, if we don't have everyone in the same tent, rather than people operating in different tents, we will continue with too fragmented and too siloed a way. And sometimes we get left behind by policymakers or politicians if we say, well, we're over here, and we don't really work with those people over there. So from a policy and a political front, it's up to us to show that. So it's about saying, both, again, recognise the particular expertise, but be more prepared than perhaps we have done before. I get this. I'm an obstetrician. I've done pregnancy research. How do I reach into pre-pregnancy, postnatal, into areas which are a bit harder? It's the same concept.
And I guess in public health, it is a collaborative field, and always has been. I'll take a question. Jenny.
So thanks very much, really interesting presentation, and some real challenges. I suppose I'm at the end of my career. I'm not a whatever. I'm a sociologist working in public health. And I'm concerned about the integration issue, really. I suppose, I think, over my career, I've seen that prevention, which is about preventing problems, growing. So you've got the health development, research collaborations, you've got the School of Public Health, 15 years going on. And that was a sense that we were really beginning to push at the upstream, the living conditions, the working conditions, etc. And I've also written about something called lifestyle drift, which is where we start with those big questions about the conditions in which people live their lives, and we drift down to lifestyle behaviour change issues. And I think, whilst I understand the benefits of the integration agenda, I think there are risks that we lose what that progress we've made, really, in addressing the primary determinants of health inequalities. And the one point I would say is inequalities are growing. They're not just there, they're not just a challenge, they're getting worse. And we need more research on those upstream determinants. So I suppose my big ask of you is how, as you move the agenda in the school, the way in NIHR, the way you've suggested, how do you protect that research investment in those parts of public health which have always been difficult to protect?
So you named something that I think is really important, which is health and the determinants of health that sit outside DHSC. And I haven't seen Kevin's slides, but he may touch on this a bit more. There are two schools of thought. One is, if you look at, as a proportion, determinants of ill health we know that the majority sit outside of the direct policy making in DHSC. So on the one hand, you can say, if we ignore all those wider determinants, poverty, housing, transport, then we will never get to the nub of it. There is a different view, which is we have to do everything we can to address the areas in health and care research where we've got more direct levers, controls. I happen to think you need a combination of both. I don't think you can do one or the other because they are so interlinked. So for me, it's about saying we must ensure that we use, from a health research and from a health policy point of view, address what you're saying, but we are going to have to work with other government departments and with the researchers. So for me, that is the linking and the integration. Now, in a research, we can do it both through what we're doing within NIHR, but for me, it's critical that we also leverage both from a policy point of view and a research point of view, which is often with UKRI, to make that happen.
Okay. I guess one point there would be, and I'm going to bring John in because he's from People's Health Trust, and so he'd like to ask a question, is that actually local authorities can change a lot of those wider determinants, and that's where the housing, the transport, they have that power, and we can help them research and have evidence to inform their practice and their policy. So we can make a difference in those areas.
So it's local authorities, but it is also the government departments that own the policy. And so there's different levers at different stages. So I'm in agreement with you. We need to keep up with that research. We need to keep that research, but also acknowledge that there's many different drivers. So, and that we both have to focus on what we can do, and we have to work with those who have got other levers.
Okay. So we've got a countdown going here, and we're just under 3 minutes. So, John.
Thank you. Thanks, Lucy. That was a really interesting presentation. I'm John Hume from People's Health Trust. And I couldn't agree more with you about cross-departmental work, by the way. I think it's absolutely critical that we get this sorted because it is working in silo and it's really difficult for the voluntary and community sector in particular to navigate. But the school has developed really good relationships with local authorities and the voluntary and community sector over the years, and they're quite substantial and they've been really essential to, I guess, to ensure that the public health research is relevant to and has utility for the communities that it's supposed to impact. So I'm wondering, as we go through the next few years and also in future iterations of the school, how will NIHR ensure that it continues to really place emphasis on those relationships and on building out so that it does actually, the work that happens does affect communities positively and also addresses those inequalities that Jenny was just talking about?
So I think that's a really important question, and partly because it relates to what we are seeing. I'm going to take public and patient engagement, but actually that often intersects with wider community engagement. They're not separate things. And one of the things we're seeing is a huge amount of duplication in this across NIHR and sometimes through other funders or groups, but let's just stick to NIHR. So the question is, we need to have, as NIHR family, a better sense of how to utilise all of those in a more, I come back to coherence, because at the moment, communities are telling me they're being approached by multiple different people, all of whom want their slice of the pie, hopefully for good, but sometimes it feels like they're being asked from multiple different bits. So I completely support where those bridges are critical, for many reasons, on a bi-directional way, not on an exploitative way, but on an engagement way, and because of the reach that many voluntary groups have into communities that we should be celebrating and supporting. But what it means is that rather than you or others being approached multiple times, that we make that more joined up. And for example, if we go back to the neighbourhood health, that needs to look like us looking at it on a footprint basis rather than on look, we've got lots of individual links here. So it's a call back for rather than going down the fragmentation route, go back to the greater good and say, come with us on that journey, because if we must have this community being part of shaping these next steps.
Lucy, can I ask indulgence? I see we've got one of our early career researchers with a question, and I know we're almost out of time, but Jax Bennett has got a hand up there, and I think it would be good to have the last word for the next generation.
Agree. Yes. It's about you. It's about the early career researchers shaping this.
Thanks, Professor Chappell. Thanks for talking to us on a day when it's particularly difficult in government as well. You talked, I've made a note here, you talked very eloquently about public health research and what this change might mean for public health research, but what about public health researchers? And what will it mean? I'm an SPHR launching fellow. This is a tertiary career for me. I have been held over the last couple of years by the School for Public Health Research. It's allowed me to develop my research. I work in young people's mental well-being. I have made networks across the UK. I've worked with other researchers to bring together a huge project of work. What does this mean for people like me who are being trained, networked, connected in schools like SPHR?
So I want that vision of NIHR to make it very clear that not only is there a place for you, but we want to grow your numbers. So if you look at what we're trying to do in prevention research and public health research, we're trying to make that a greater part of our portfolio, and we have written commitments to do that. I think there is something really critical, and this is where NIHR is its own success. We have made ourselves more inclusive than ever before. We know that from who is coming in. And one of the challenges is that but in doing so, and in reaching out to more disciplines than ever before, we only have finite amounts of money each year. But what we need to do is make sure that we are carving out not just our capacity building, but our mid-career and our tenured places at a time when, for local authorities or for universities, that is more challenging. So one of the things that we're seeing is that as universities exit from tenured posts, we are picking up the slack with a number of schemes, and they continue to exit. And I don't have the solutions to that for local authorities or institutions. What we can do is support careers and high quality careers and say we will continue to have a range, and by increasing our capacity building across infrastructure and programmes, we are making that clear. Fellowships are not the only route to hold those posts. We want to make it more inclusive and broader and give you hope that we very much see the future for public health research and public health researchers.
Thank you, Lucy. And I think our early career researchers, mid-career researchers and senior researchers look forward to having opportunity to work with you and others in NIHR to shape that future, to make sure that what we've got in the essence of it is protected and distinct, but that we can grow that. And and we look forward to that growth and working with you on that.
Thank you.
Thank you. Can we thank Lucy, please? And good luck with the rest of your day, Lucy. Okay. So, I think now I'm going to bring us on to our next keynote speaker. I am delighted to be able to welcome Professor Kevin Fenton. Kevin is the London Regional Director of the Office of Health Improvement and Disparities, otherwise known as OHID, and the Regional Director of Health at the NHS London. Within this role, he's also the Statutory Public Health Advisor to the Mayor of London, and the Greater London Authority, and Regional Director for Public Health for NHS London. What do you do for the rest of your time, Kevin? He's also the government's chief advisor. This is what he does with the rest of his time for HIV, and the chair of the HIV Action Plan for implementation of the steering group for England. Before taking up this role, so these are things you have handed on, is that he was the regional director for London and held the joint position of strategic director for place and wellbeing and director of public health for Southwark. Now, Southwark, I happen to know, have been exceptionally successful with firsts, and was a senior advisor to Public Health England. He's also past president of the Faculty of Public Health. Kevin was awarded a CBE in 2022 New Year's Honours List for his services to public health. Kevin, you're really welcome. We look forward to hearing what you've got to say, and also to have some questions with you later. And I think Kevin's going to hang around for some of this morning. Thank you very much, Kevin. Try that one. If it doesn't work, try the other one.
Good morning, everyone, and thank you also for this fantastic, warm welcome. I am so pleased to be here with you today. This is the third talk that I'm giving on research, the research environment and public health research in the past 2 weeks. And I fear that some of you in the room may see some slides that you recognize from previous talks. But for today, I've changed focus a little bit, because what I'd like to do is to build on Lucy's excellent opening talk to reflect on some of the macro changes which I see in my role as a Public Health Director for London. And then to contextualize these changes, these trends, these imperatives into what it might mean for us in our city. And I hope that by telling that story, by highlighting some of the challenges that we're faced with here in London, you'll be able to see yourself in those challenges and those opportunities. You'll be able to say, actually, here's where you may go differently in London to what we're doing in other parts of the country, or indeed, what we might learn from you. So, in the time that I have available, I'll begin with a little bit of a contextual overview, and then we'll go a little bit deeper into the ecosystem in London, how it's changing, how it's evolving, and what we're planning to do differently. So I've titled this talk From Insight to Impact, because as the Public Health Director and a person who straddles academic practice and public health practice, I am resolutely focused on impact. I'm resolutely focused on improving population health and tackling inequalities. And I have to be ruthless, because given the environments that we're operating in, the economic, the social, the cultural, the widening inequalities, which was mentioned earlier, we have no time to waste. We have to ensure that the research that we're funding, that we're doing, is eventually going to help us to do things better, to reduce inequalities and tackle some of the big challenges that we have. Now, I would argue that we're not short of research, but indeed what we're probably short of is demonstrating the impact of that research. And you saw that in Lucy's presentation, whether in the ways in which we tell our stories about what we're doing, or indeed in the real-world impacts that we're seeing on our day-to-day practice. We know that research output is in fact increasing. Biomedical research investments, capacity building, the infrastructure, you saw this in Lucy's talk. This is not an environment where we are in a phase of decline, although we are in a phase of evolution when it comes to the research ecosystem within our country. At the same time, however, we see that we are stalling in a number of our health indicators, whether it is the stalling in UK life expectancy, which has occurred from the pandemic period straight through to, in the most recent data, we're seeing early indications that that might be changing. We're seeing some reductions in healthy life expectancy in many parts of the country. And even if you disagree with how healthy life expectancy is measured, the fact is, as an indicator, it is declining, and it is extremely heterogeneous across the country. And so, as we look at these and we hold these conflicts, that we're spending more on research, we're doing more in this space, yet our health indicators are changing and declining, we need to ask ourselves, are we doing the right things? Are we doing the right things for the right people? Are we able to have research that helps us to fundamentally reshape the ways in which we're developing and driving programs? At the moment, I think there are a number of key influences which are converging on us in public health practice. I've already mentioned the worsening health indicators that we're seeing on many fronts and the widening health inequalities. But as a global city, London is also intimately connected to what's happening globally as well. So whether it's the funding in global health cuts and the deterioration in global public health programs and the impact that it has on migrant populations and migrant communities that we have here in the city, whether it's global conflict and how it manifests itself both in terms of connectivity for health, impact on mental health and social cohesion. And of course, this is a dynamic time of change domestically as well. So at any given time in London, as the Public Health Director, we're looking at national policy, for example, the 10-year health plan. We're transforming the health and care system through the integration of the department and NHS England, the creation of new ICBs, integrated provider organizations, new neighborhoods, and we're looking at local and regional policy as well, with combined and mayoral authorities in this space. But as the Public Health Director for the city, not only am I focused on what's happening in the here and now, but I have to keep my eyes on the future, looking at future risks and how we prepare our city to be more resilient. One of the tools we look at and use is the World Economic Forum Global Risks Perception Survey that helps us to think about risks both in the short term, in the next 2 years, and in the longer term. And over the past 3 years, it's been interesting to see how the short-term risks have evolved. 2 years ago, number one was misinformation and disinformation as we emerged from the COVID pandemic and had to deal with both the response to the pandemic and the fallout of that. In this year's report, geoeconomic confrontation came first, misinformation and disinformation, and hopefully you're seeing yourselves in these risks. You're probably doing work on societal polarization, the lack of social cohesion, and the impact that that has on trust and confidence in public health interventions. Many of you will be working on climate change, its impact on physical and mental health. And of course, increasingly in an environment globally where we're dealing with state-based conflict, understanding its impact on our communities and the impact on mental health and well-being would be key. Inequalities are there on the short-term list. If this was perhaps done through a Delphi process in this room or in England, I'm sure the ranking of these short-term risks would change. But this is a useful exercise, I think, for us to use. In the long term, those green bullets highlight some of the risks which are uniquely associated with climate change. So for the next 10 years, looking at the impacts of extreme weather events, the impact of biodiversity loss and ecosystem collapse, critical change to Earth systems and natural resource shortages, and consequently, as a result of the climate impacts, multiple system or multiple order effects taking place, again with misinformation, the role of technologies, and cyber insecurity. Again, keeping our eye on both those global trends and looking at the demographic and healthcare trends in London will be critical. So this global instability and global changes, I think, will impact and should impact our work. To what extent should we be looking differently at pandemic preparedness, and should we be investing more, given our experience with COVID, looking at what's happening now with the hantavirus? Are we in the place that we need to be with surveillance, behavioral insights, understanding trust and confidence in public messaging, and really thinking about how we integrate data to build our resilience? Are we ready for climate shocks? And is our research portfolio beginning to shift to think about the major challenges that we have ahead when it comes to climate change? We're not looking forward to a hot summer in London again, because we know it increases the pressure on the NHS. It has a significant impact on mortality in older individuals in the city, and it results in social impacts in terms of higher likelihood of riots, fights, and violence on the streets. We've been able to document this consistently in the city in terms of the impacts of climate change. Migration and displacement clearly is going to be important for us. Is our work more culturally competent? Are we implementing anti-racism frameworks? Are we listening to and engaging migrant and displaced communities in the work that we're doing in real and meaningful ways? Are we still doing the engagement with established communities and not recognizing the diversity and evolutions of the people whose services need to be reaching? And then finally, all of this is having an impact on resource constraints, because as governments are dealing with these multiple threats, it means there is often less resource available for domestic investment. So how do we use those resources most effectively? Looking at the cost effectiveness of our interventions, the return on investment, value-based commissioning, which is an important part of our work in the NHS and social care. The final aspect of changes that we're looking at very carefully is, as I said, the changes that we're seeing in healthy life expectancy and life expectancy. And certainly across a city such as London, we've been seeing significant trends. So although national figures for healthy life expectancy have been on the decline, in London they have generally stayed constant for men and have only recently been declining for women. In the most recent data, we're beginning to see a dip for healthy life expectancy for both men and women. But characteristically, in London and across the country, we're seeing significant differences in the inequality gap for healthy life expectancy of 14.7 years for men, and some of the lowest healthy life expectancy and life expectancy seen in the most deprived parts of the country. Now, the most recent data on life expectancy suggests that we're beginning to see finally an uptick after the 5 years post-pandemic period. We're seeing now some of the lowest all-cause mortalities being recorded in the country, with specifically reductions in cancer and CVD mortality. So it's a testament to the work that we've been doing, both in the clinical space, but also understanding prevention interventions for cancer, for CVD, and the impacts that they're beginning to have. We know that there's inequality geographically, and Lucy alluded to some of this. London has the highest life expectancy in England. The North East has the lowest. And of course, all-cause mortality rate is 25% higher than in London, in the North East than in London. And this gap is a key part of the picture that we're seeing and the heterogeneity that we're seeing across the country. So at this point, I think there are key takeaways, just to give you a sense of the conversations that I have as London's Public Health Director. It's both understanding how the domestic picture is evolving. As a city of 9 million people, how do we understand health threats, healthy life expectancy, their determinants, access to healthcare services, and the ways in which we are designing and commissioning services to address these challenges, while at the same time keeping an eye focused on what's happening globally. But at the third time, ensuring that we're working with our partners and stakeholders to say that given these threats and given this complexity, leadership needs to change. Leadership needs to change at all levels, both in terms of the policies we're developing, the programs that we're commissioning, the need for us to be agile and adaptive, given the nature and complexities of the changes, and to ensure that we're developing programs which are sustainable, scalable, and focused on impact. These themes are reflected in pan-London strategies that we have developed, working across health, social care, and other sectors. So whether in the new London Health Improvement Plan, London's Health Inequalities Strategy, London's Growth Plan, London's Life Science Strategy, and London's Innovation Strategy, you will see these themes of preparing and responding to today's challenges, building a resilient city while focused on the global and national, and thinking about the leadership transition that needs to be in place. So I've started there in order to transition to the challenge that I think we have working in public health. And as I've had this conversation with HDRC colleagues in London, and we're now developing the proposal for the new London Applied Research Collaboration, it is critically important that we begin to build upon the things that we now know so that we can be better and more focused in our research within the city. And the key question that I keep asking to my academic peers and colleagues and my policy colleagues is, how do we become more than the sum of parts? As Lucy illustrated, there is an ecosystem. It's diverse, it's changing, it's dynamic, but it's also in risk of being fragmented. So the question becomes, can we be more than the sum of parts for the communities that we're serving and for the priorities that we identify? Now, Lucy has already identified and spoken about the 10-year health plan. It certainly is the drumbeat, the North Star to which we're all working towards now. And we fully embrace the shifts which are being envisioned from sickness to prevention, hospital to community, and analog to digital. And in London, not only are we adapting and responding to this, but using the 10-year health plan, have identified our own London health plan for the NHS, which are prioritising 3 key things where we want to go further and faster with our research colleagues in order to exemplify and to accelerate impact under the 10-year health plan. So across London, working with our partners, we've prioritised heart health, CVD prevention, through our Million Hearts and Minds programme. It's now the largest regional programme focused on cardiovascular disease prevention in the country. It's an opportunity for us to look at the CVD prevention pathway, optimise it, bring innovation, bring new partnerships, new energy, new funding, to think about how we address the #1 killer in London and the greatest driver of health inequalities in the city. The second key priority for London is focused on neighbourhoods and neighbourhood health services. And as Lucy said, ensuring that we're bringing to our neighbourhood thinking the best research and applied research that can help us to understand models of care, to evaluate in a much more rapid and agile way what we're implementing so that we can do and learn and scale much faster than we've had before. How we leverage some of those place-based partnerships with academia to help us to understand population health management, use of data, new technologies, and to ensure that neighbourhood services are way more culturally competent than what we had previously. And finally, opening up our innovation and life sciences space for technology, AI innovation and digital in new and exciting ways. In London, we want the NHS app to be the front door for all NHS services over the next 3 years. That should be your first point of call, but not the only point of call, but to leverage the NHS app to introduce Londoners to an ecosystem that can help to support them along their journey of better health and well-being. In London, we also have a fantastic ecosystem for public health research, more than 40 universities and higher education institutes. We're now working on a single arc that will cover both all of the universities led by UCL, Imperial and King's. And this will be a fantastic opportunity for us to marry some of the earlier threats and opportunities I mentioned with a stronger research architecture. We have more than 3 now local authority HDRCs across the city, 33 London authorities. And in that ecosystem, there are many other health and care players highlighted on the slide, which we're now beginning to bring together in a much more systematic way. And the ARC is going to be the next intervention for us to complete that integration between the research and research ecosystem with the delivery side of what we're doing in London, bringing to the table our partners in UK HSA, local government, primary care, or charities, the ways in which we're working with communities and the ways in which we're working with businesses and industry to begin thinking about how we do things better in the city. And that innovation ecosystem is critical because we know in London we are an innovation hub for the nation and indeed for Western Europe with more than 2,700 life sciences companies. The life sciences turnover in the city is about £33.9 billion, a significant number of individuals employed within the sector, and we're the #3 global life sciences city. But we want to go further and faster with that. So at the moment, we're looking at frontier innovation, developing our innovation pathways. And I'm really pleased to say that public health is at the table in thinking about innovation strategies for London and what it might mean for us, not only in diagnostics and medical technologies and medicines, but thinking about innovative ways to modernize our public health practice, to do public health in new and exciting ways. So this will require us to move beyond universities, really thinking about how we partner with industry, really how we leverage new data, integrated data platforms, to think about the assets that we have in the city and how those assets can be more attractive to international companies. We're creating the London Health Innovation Zone as part of our 10-year health plan commitment, which will position London to take full advantage of government's own investments and strategic prioritisation of innovation. We want to begin to think about how we make translation and dissemination implementation a lot easier across a very fragmented health ecosystem. We want to ensure that London is clear about our priorities for innovation, which will take us from health to quantum, to building, to regeneration, many other fields which are incredibly important for us as a city. And we want to be able to break silos down so the health and care system is not just speaking to itself, but is now intersecting with planning, regeneration, other sectors to begin thinking about the wider determinants of health and how innovation can be brought to that. So, this sounds really exciting. How do we make this happen, and what might some of the challenges be? Well, I think there are things that we will have to focus on in the years to come. Let me say that again. There'll be things that we'll have to focus on in the months to come, because there is an urgency for us to move with intention to create this ecosystem to do things differently. We're going to have to deal with our connectivity, because it's currently our weakest link, as I mentioned, because of system complexity, the churn in our workforce that I've described, institutional silos, and data fragmentation. So the ways in which we're bringing systems together now to focus on these 4 areas will be critical. But there are other areas we're going to have to focus on next. We need to begin to move together, because we're not doing that enough. We need to reduce duplication. We need to avoid the silos and an even research capacity which exists within different sectors. We are so excited about the HDRC in the city, but that only covers less than 1/5 of all local authorities in our city. And there's a need for us to think not only for the core investment, but how we bring others along. And as we create new organizational structures through the NHS reorganization, what does it mean to link research with neighborhoods, to link researchers with new ICBs, to think differently about the ecosystem and ensuring that we're working together? Second, we need to continually ask ourselves, who are we designing this research for? To what purpose and with what end? And how to ensure that the research which is being designed in London is uniquely meeting the needs of London's populations? So for us, if inclusion and equity and diversity is not a core theme within the research, I would argue, why are you even doing it in our city? If it is not credibly including the people most at risk in London, then it should not be funded as London research. And I would go even further, because the lessons from COVID should suggest that we need to be asking very different questions in our city. Who is the community that we're targeted? Will inclusion health groups be visible in the data and in the findings? And how are we implementing anti-racist frameworks and approaches in how the research is being conceptualized and implemented? And will we have the workforce and the policies to deliver on the results of this research and the capacity to act on it? Those are questions that I think, and I hope, will help you as researchers to begin thinking about the adaptability and translation of that work. And the reason why we have to be more proactive is because of the populations that we have in the city, highlighted on the right side of the slide. We have to do much better on translation, implementation, and scale. We know that there's a lot of great research being done across the city, a lot of innovation which is stuck in a provider trust, is stuck in an ICB, and we're not able to get it to translate to benefit the 9 million people in the city. And whether it's the innovation with the NHS health checks or cholesterol and blood pressure management programs, what we're doing in tobacco, it is taking way too long to translate and to spread innovation and best practices across the city. So in our thinking in London, we're thinking about asking questions. What's scalable and what isn't? And how do we begin to think about scalability at the beginning of our intervention development rather than at the end? And how do we build in equity of adoption within the work that we're doing? There's an element about de-implementation because we don't have enough resources to do everything all the time. So what do we stop doing? And how do we say, actually, we've tried this, it's not working, we need to be more agile? And again, how do we do real-term evaluation at scale? I think I have final 2 questions before finishing. How do we move from individual projects to collective impact? Because it's really great that we're able to do interventions and studies in single boroughs, single institutions. We're going to think through borough by borough work. We may be engaging communities in individualistic ways. But again, the nature, pace and scale of the needs that we have in the city should dictate that there are opportunities for us to do this differently and better by looking at shared London priorities, by looking at shared protocols that we do want for London, that when you approve an innovation in an ICB that automatically passports you into access for other ICBs in the city, that we have standing community panels that speaks to the point that was made earlier, which is helping in the co-production agenda, not just for research, but for health programs as well. And that translation into policy briefs and not just academic papers becomes a critical part of what we do in the city. So this is my final slide. And this is a slide I ended with at the HCRC conference last week, and it was a call to us about what we will do differently. In many ways, this is the best of times in terms of the research environment, ecosystem, and funding. It's wonderful to have this investment in public health research. But what will you do differently after today? Sure, you'll be connecting with each other and asking each other to reflect on Lucy's talk, on my talk, what we're doing in London. And for those of you who are based in London, does this resonate with you? But I need us all to share our experiences and continue to share because we have so much to learn. And for those of you coming from Manchester today, I have to say there's a friendly rivalry between our cities, which I love. And one of the things I often do is to say, well, what is Manchester doing on this? And can we do it a little bit better? So to you, but please don't tell anybody and don't tweet that. How can we do better with co-production? And it's so good to see the diversity in the room today. But most of all, how do we continue our focus on impact? Thank you.
Thank you, Kevin. And we have some time for questions. So thank you. I reminded in your last slides there and the last bit of your presentation about generating impact. And whilst we were here yesterday for our first day of our annual scientific meeting, on Tuesday we had our Researcher Network Day. Mm-hmm. And I know some of the people who were at the ResNet Day are here in the audience. And one of the questions that they were asking, and we had Jen Walters from the NIHR Comms lead, was how do we engage and get that research into impact? So within the school, co-production is core to what we do, and we don't fund anything unless it includes co-production with the people who are going to be impacted and work in that. And that's something we've worked really hard to achieve. And so that co-production. But what's often really challenging is finding the right policymaker at the right time that hasn't moved. So they may be involved in in work in the beginning, and then people move and sort of keeping track of all of that. So it might be that some people that in the audience and also those that ResNet could ask the same question of Kevin about how do we do that engagement, which we do, but then actually get that translation and into for impact. So I am going to look at Slido to see if there's any questions on that. But before, and please do put them on there, but I'll see if there's any questions from the floor.
Shall I just respond to that initial opening statement?
Yeah.
So you're absolutely right. And it would be a shame if anybody left and thought that actually I was putting the blame of translation on anyone's shoulders. It is what it is, because it is the partnership between academia, policymakers, and program implementers that results in, and communities, that results in effective translation, dissemination, and scale. And while policymakers and program implementers have perhaps a greater role to play, it takes a village. It really, really does. We see this, for example, in the work that we do on HIV. Lots of innovation, the availability of HIV PrEP, new ways of doing HIV testing, new diagnostic tools and technologies. That partnership between policymakers, clinicians, the community is absolutely essential in moving forward. And why? Because there are three key elements. One is the advocacy for getting that translation prioritized into policy and programs. Number two, it's the accountability which is required. So we know if there are new technologies for HIV and they're not approved by NICE, and if they're approved by NICE and not implemented in the NHS, the community will hold us to account for implementation. And then there's an element of accountability for scale, that actually London may move forward first with an innovation, but the community will say it is not acceptable that this technology, this new approach to tackling HIV is only available in London. We will advocate nationally. So that partnership, I think, is key as we think about this implementation and impact space.
Thank you, Kevin. Questions? There's one here. Thank you. We're just going to come with a mic.
Hi, Kevin. Thank you very much for your talk. I'm Laura Fenton, no relation, obviously, from the University of Sheffield. I really enjoyed hearing what you had to say, and I kept thinking back to Jenny's question to Lucy Chappell. And I guess there have been two, for all the criticisms of the government, there have been at least two important upstream policy interventions in the past couple of years: the lifting of the two-child benefit cap, and more recently, potential improvements to renters' rights. And I think these, could potentially have a huge impact on the health of Londoners. And I guess where does the evaluation or other ways of approaching these kind of upstream policy interventions fit within the framework that you presented? Thank you.
So they do, and I'm hoping that as a result of bringing together our London colleagues to work in a more integrated way with the London ARC, we'll be creating a new platform that brings policymakers, program implementers, and the big research community together. We're using ARC as a structural intervention in London, and maybe that itself should be a research question in the future, because there's no forum at the moment that brings colleagues together to do exactly what you've just said. In light of this new intervention from government, how is London going to organize ourselves? What is the HDRC going to do? What are you going to do in the ARC? What are we going to do in the other research centers that we have in order to understand its impact? And that's important because they're not the only two. If you look in the growth space, in the innovation space, in education, there are lots of policies which need to be both contextualized for London, but also understood for London as well. But I don't think we have the mechanism for both reflecting on that and then agreeing what we want to prioritize, what's necessary for moving forward. So the London ARC will have a new partnership board which will bring these partners together, and those are the exact sort of conversations that we want to have, because the partnership board needs to be agile in terms of priorities and imperatives which are coming. It needs to be inclusive, so we have a wide range of partners working with us, and it needs to help to direct the priorities for what the ARC will focus on as well. So thank you for that. We're thinking about how we do exactly that in the city.
Thank you, Kevin. And we've got a number of colleagues in the audience here from London universities. So I very much hope that the researchers are going to be part of that collaboration, because we have work on the areas that you've just described, and having that conduit and part of that partnership. So yeah, research is part of that that arc, and obviously it is very much it will be there, I'm sure. There's a question here. Peter, please.
Thank you. Thank you, Kevin. I'm Peter Hart. I'm involved with public involvement at the school, and I really enjoyed your talk. My concern is sometimes we have an initiative, an innovation, and before we know the impact that that's having, we move the goalposts. And I'm thinking, I do a lot of work in alcohol. I have lived experience in alcohol. The lack of structure has been evident since the first models of care in 2003. And so, for instance, alcohol care teams, I'm working on a project which looks at the efficacy of these teams. And before we've got to the results, these teams the sustainability is a real issue, and they're being struck off the spreadsheets. I wonder if you could comment. I mean, I believe in change, and I believe in everything that you and Lucy have said today. But I'm also concerned that, yes, we're moving the goalposts before we really know whether our initiatives are working in the first place.
You know, Peter, such a great question. And if I'm honest, that's just the messiness of public service. It's the messiness of public service in the 21st century, when we're dealing with all of the threats which I mentioned, where at any given time, programs that we thought were sustainable, long-term and necessary are being questioned because of the economic pressures that we find ourselves on. So the question I ask myself, Peter, is not should we continue to hold on to a particular model, for example, brief alcohol interventions within the hospital setting, which are so important, evidence-informed, but can we adapt, improve it? Are there things that we can do with our research colleagues to think, can the model change? There are many things, Peter, that we thought we couldn't do digitally. In London today, if you're worried about any sexual health condition, your first point of call is going on a website, ordering a test, and getting tested for HIV, STIs, etc. 10 years ago, that was radical. People said you couldn't do that. Today, for every Londoner, it's default. It's digital first before moving in. But the pressures of the economic realities that we had forced us to think differently about that clinical service and forced us to develop a whole research infrastructure to understand it, and then we have a different service. So I wonder, to your point, there's an element of we advocate to keep our programs where we can, but where it's difficult, we work with colleagues like yourself to think about what are the new models, what are the new opportunities, and how do we bring our research into understanding that as well. We have to be more dynamic, we have to be more agile, because it's the reality and the messiness of what we're working in now.
Thank you, Kevin. And just in case anybody thinks I'm ignoring Slido, that there is nothing on there. So you're all just putting your hands up, and that's perfect. So I saw there's one here, and I think there was also a hand there. There's lots going up. So I'm going to ask you to keep your questions quite short, so that we can get lots of questions in. And there's also a question up at the back, which I am going to take in a little while. That's from Rowan, because it was relevant to the point I made earlier on. So here first, please. No, yes, we need a mic.
Thanks very much.
Oh, Rowan's got a mic, has he? Yeah.
I do have a mic.
Okay, Rowan, then we'll come here. Thank you.
Thank you, Ashley, and thank you very much, Kevin. My name's Rowan. I'm from the University of Exeter. I'm an early career researcher. And I'm thinking about, as I'm starting to move into planning my own research more independently, it seems very big to try and think about implementing research in such a messy context, but trying to plan research in a way that is going to be effective and useful. And I wondered if you had any thoughts about navigating the bureaucracy, thinking about the big picture in a way that could be a little bit more accessible for somebody starting out in a research career.
So, Rowan, thank you. I had the privilege of chairing the UK Prevention Research Partnership Programme for the Scientific Advisory Board for that for its first 6 years. And one of the key areas of focus of that was looking at public health research using complexity thinking, complexity models and systems to help us to do exactly what you're saying. In an environment where there is complexity, many partners, many priorities, different imperatives, different values, how do you cut through and how do you ensure that you have research that is able to have impact within that environment? And Rowan, there are many lessons that we learned. But again, I'll focus on 3 which I think are critical, especially in your phase of your career. The first is that coalition building and partnership working is the sort of foundation on which we all need to be operating today. And the strength of your research and the implementability of your research is predicated upon the nature of partnerships that you create at the beginning of conceptualizing your project. The days of thinking of a research project in isolation and then coming and bringing it as a fait accompli to say, here's my idea, have ended. have absolutely ended. And I think the School of Public Health Research would argue that that is not your model, that you co-produce as much as possible from the beginning. Because ultimately, you need all of those partners around the table at conceptualization in order to do the work. Second, recognizing, and we learned this from UK PRP, that any answer to any question in a complex environment will require multiple perspectives working together. So again, your partnership is not just the coalition, but having different kinds of researchers working with you. So if you're an economist, if you're a qualitative researcher, if you're a community researcher, having them around the table to answer and to ask the question is going to be critical. The third lesson we learned in UK PRP is the ability to be agile. Because in a complex systems, things don't often work out. And often, many of the proposals and projects which were identified at the beginning of our UK PRP journey, many of them didn't work out. We had to change. We had the pandemic in the middle of it. That agility means that the ability to pivot, the ability to bring your partners in to say, what are the new imperatives we need to be focused on, will be critical. So 3 things, Rowan, that I think are different to when I started research in the 1990s, but I've embraced in my public health practice today, and I'm keen to see that more in our researchers as well. I hope that helps. But that's how I navigate as well some of the complexity that we're dealing with now.
Okay, suddenly, my good friend pressed a button and I have got an absolute screen after screen after screen of questions. So I'm so sorry.
I was beginning to worry. I was thinking nobody had a Slido question.
Well, yeah, but so I was enjoying our audience interaction, but we have got loads. So we could keep Kevin here for another hour and a half. But there is an idea in here which I really quite like, which I'm just going to mention, and then if we can maybe have just one of the things that's been suggested here is, could we have people like yourself and others and civil servants actually come and tell us about one piece of research or 2 pieces of research that really changed their practice and how?
Yeah.
Now, I think that's actually quite a nice idea for something, because when we do have that, but actually it would be good to know what made that difference and how, and what kind of dissemination. So I think that's something for the future. I am conscious that we are over time so Kevin, I know you're going to be around for the rest of this, hopefully this morning. We're going to have some short presentations and then a break. So Kevin, expect a queue. Okay, so if you could form an orderly queue, please, and do get Kevin a coffee as well while you're doing that. Can we, meanwhile, just thank Kevin? Thank you. We do standards now. Okay, thank you. Thank you very much, Kevin. So I am so sorry to all of you who are putting questions on Slido. That's completely just my ineptitude. I'm sorry. Right, so now I think I'm going to invite my colleagues PI&E and GJ to the stage. And I'm going to move to one side whilst they do their... so what we're going to do now is do some presentations for our public involvement, engagement and EDI.
Thank you. Thanks, everyone. This is a really special part of, I think, the ASM, and I wanted to thank everyone who has been involved in nominating people for these awards. We're going to start with the EDI awards, I think, and just wanted to say, just a reminder that we do have members from all members. We have one person who represents them on the EDI committee, and I'm thankful to all of those people for having helped us to think through and look through the nominations. So for the EDI awards, we had 7 nominations. They were all excellent, and I think it was really difficult for us to come to a decision because they all had elements that demonstrated what we heard about this morning about the importance of EDI in all the work that we do. But I think in coming to some conclusion from these to come up with our winners and runners-up and winners, what we took into account was to what extent they demonstrated EDI principles, not just in the research study, but also in other aspects of the work, the workforce, the dissemination, and so on. So, the exciting thing, we ended up actually having 2 runners-up because they were so excellent. So our runners-up are Bina Ram, and I'm not sure if any of them are here, so I have to just say, Bina and Amita Retzer. So Bina's work was about school environment. Wonderful, thank you. Well done. Thank you very much. I've got the right one for you. There you go. Right. And our winner for this year, I will take it out of the gold envelope this time and press the button, is Helen Moore. So well done, Helen. So well done. Sorry.
Oh, thanks, PI&E. So, as we all know, effective public involvement and engagement is core to all of the research that the school does, and I'm really proud to be the school's Associate Director for Public Involvement and Engagement. As is always the case, we had a number of really strong nominees for awards this year, and I think these really reflect not only the importance that we place on involvement and engagement, but also the importance that we place on creativity and innovation in the involvement and engagement that we do. We had several nominees. Each of these nominees were distinguished again for the innovation, creativity, and commitment that they brought to involvement and engagement. And as we had with the EDI and I awards, we were fortunate enough to have some runners-up as well. And our runner-up is exploring the impact of family size on child health outcomes and service use project team. So if you're here, please come on up. And our winner for this year is Hannah Crease from Imperial College London for her work on persistent school absence. And now I will hand it over to you, Ashley Adamson.
Thank you, GJ Melendez-Torres. Okay, so this is the last set of awards, and you be aware we instigated these awards. I keep picking that mic up and I don't need it. We instigated these awards a couple of years ago, so I'm really delighted that actually this year we've got a couple of categories of awards. So I'm starting with some the award for impact in communication, and I think, oh no, too soon, too soon. One for communication, and so we have got had some excellent work over the last year in communication across with each other, outside of SPHR, and with our public and community partners. The first of these awards goes to Marco Bardas for his Health and Risk Communication Network, HERACOM, and his webinar series. Marco has arranged 19 webinars between April and July this year, and the second award goes to Karen and Sharon, as we like to know them, who have instigated the Researchers in Making podcast. And if you've seen any of these, they're really great. And there was one done live at ResNet on Tuesday with one of our alumni. The series has had 403 streams and downloads, 227 plays of the series, and we want to get it out there and promote it because it's about researchers and the challenges
opportunities that they have in making their careers and things they learn along the way to make impact. So it's great. So have we got Marcus here, or have we got and Karen and Sharon? Marco. Okay. So, I'm going to, come on up. Okay. Marco, that's for you. Now I have to get the right way round. Oh, have I done that right? Is that right? I did it right. Okay, congratulations. Now, the third award, it goes to, this is a Director's Special Award for Added Value. And this award goes to somebody who many of us know really quite well, who has recently been promoted to a Professor of Public Health and has stepped up this year to be co-lead for the Children, Young People and Families Award programme. And she's going to be representing SPHR at Evidence Week in Parliament in July to present her work on housing insecurity. Professor Hannah Fairbrother has recently written a blog to reflect her experience as being part of the school, growing up in the school, and talks about the opportunities and support that she's had through the school and through that network, and describes the school as a really hopeful and productive research community. Hannah, we absolutely agree. It is absolutely that, and everybody contributes to that, but you have particularly. So Hannah, please come on up.